Chapter 48, Nursing Care of the Child with an Alteration in Metabolism, Endocrine Disorders. I've also included Chapter 49, which is Genetics. In this chapter, we're going to talk a little bit about some specific disorders of the endocrine system that affect children. We're going to identify some medications and treatments for endocrine disorders, and then we're going to talk a little bit about some genetic disorders. One of the first disorder that we speak about is growth hormone deficiency. So it used to be called hypopituitarism or dwarfism. And what it is kids with poor growth and short stature. And the growth hormone is released throughout the day, but mostly secreted at night. And so that's often when we give the growth hormone therapy. It affects quite a few kids, about 1 in 4,000, and it's usually first identified using those growth charts. So they may have a normal birth weight and length, and then within a few years they could drop down to the 3rd percentile on the growth chart. Some of the complications associated with growth hormone deficiency could be altered carbohydrate, protein, and fat metabolism. They could become hypoglycemic easier, having problems with glucose intolerance. We talked in the musculoskeletal chapter about SCFE, so slipped capital femoral epiphysis. They're more at risk for that. Leukemia, and then some infections at the injection site, edema, and sodium retention. Primary causes of this could be any kind of injury to the pituitary gland or the hypothalamus. Could be a tumor, could be some problems during birth, some trauma during birth. It can be associated with other syndromes that we talk about. We don't really go over Prader-Willi or Turner, but often genetic syndromes are, we see more than one in kids. It could be idiopathic because we don't really know. It could be a nutrition problem. And it also can we can see some psychosocial issues too with it. So the treatment is growth hormone replacement. The next thing we're going to talk about is precocious puberty. So that's where the child develops sexual characteristics much before the usual age they should. So in girls, they should go through puberty about 10 to 12 years old, boys about 11 to 14. And what we see in precocious puberty is they start going through puberty between 8 and 9. It's more common in females, and they're not really sure why. If we see it in males, it's because of a structural CNS abnormality. So education is really important in this this disease process because these kids, because they're go already through puberty at a young age, they could look like they're older and be more at risk for sexual abuse, things like that. They would administer hormones to help them and hopefully slow that process. Again, early identification is important. Self-esteem is one of the things that we are concerned about with the precocious puberty because they have anxiety to, their body, how it's changing, how they look to other people, things like that. Another thing that we're going to talk about is congenital adrenal hyperplasia. And so with this syndrome, it's an autosomal recessive disorder, and there's not enough enzymes that synthesize the cortisol and aldosterone. So it happens. It doesn't happen frequently, but when it does happen, it's very concerning to the parents because even though they have normal genitalia on the inside, on the outside, it could look like they look like a boy. So you can see in some of the pictures, there's a good picture in your book too that shows it. What happens is the clitoris is enlarged and it could resemble a penis, and the labia are kind of rugged and they're fused. So they have internal reproductive organs, the ovaries, fallopian tubes, uterus, and so it's very concerning to parents when a child's born with ambiguous genitalia. So a lot of support is really important in this. And so usually they will do surgery. They're treated with hormones, and a reduction of the clitoris and the opening is done usually early, 2 to 3 months old, and then other corrections as needed. So long-term follow-up is important, and then support for the family. Just a little review on diabetes. We're not going to really go into a lot of this because you have learned this in second semester. You'll go further into this in fourth semester, but just a review of it. Gestational diabetes you'll go into when you go into the OB chapter. What we're concerned about is diabetic ketoacidosis. So often when a child is diagnosed with diabetes, it's because they came into the hospital in a diabetic ketoacidotic state. They don't typically have the same signs and symptoms that are noticeable to parents. You know, you're not really controlling how much they drink or seeing them, how many times they're going to the bathroom, things like that. So sometimes they'll come in vomiting, nausea, just looking kind of sick. We do a blood sugar and it's 400, 500, 600. And so they're in a diabetic ketoacidotic state. So that's it's really hard on parents because they think that there's more of a GI issue going on, something like that, and now this lifetime change of becoming a diabetic. Kids do very well with diabetes as far as carb counting, things like that. When we get to the stages of adolescence, teenagerhood, young adults, sometimes when they're controlling their own medications, they will just stop taking them. In my experience, we've had some concerns with youth who are homeless, so losing their supplies, and then they'll come in a ketoacidotic state. When they come in that state, it's an emergency. Early recognition, prompt intervention. You want to get 2 large bore IVs in. You want to get fluids hanging. Eventually, you get insulin hanging. You want to do your blood work. It's sort of a one-on-one patient for a while when they're in the ER. You're titrating the insulin with, following the blood sugars, following the electrolytes, and getting to that point where they would be sent to ICU. They're always kept NPO. What happens in diabetic ketoacidosis or DKA, it's the deficiency in the ineffectiveness of the insulin in the body. So they become anorexic, nausea, vomiting. They look sick. They look toxic, we kind of call it. So sometimes altered level of consciousness, confusion, abdominal pain. They could have the Kussmaul breathing, decreased skin turgor. So some people can smell the fruity breath, but some people can't, the acetone breath, and then ketones in their urine and blood. Very serious state. Like I said, you have to reverse that ketoacidosis because it can lead to death. So people at risk, obviously, for is family history. So parents or relative with type 2 diabetic, your ethnic background puts them more at risk. Other conditions that are associated with insulin resistance, history of maternal diabetes, or gestational diabetes even. And then older than 10 years or onset of puberty, if it occurs before 10, that's typically, they're more at risk. And the only condition we're going to talk about in genetics is Down syndrome, so trisomy 21. It happens frequently, but about 85% result in a spontaneous abortion. Maternal age, they say, has something to do with it, and they have different chromosomal abnormalities as far as intellectual disability, although I've seen some very high-functioning Down syndrome children with Down syndrome in my experience. Facial differences, they can have cardiac defects, hearing problems, but over the years, there's been such an improved prognosis with these kids. They have been streamlined into schools. So it really depends on the severity of it and also the interventions that happen. And that's it.